if you go into details, you are lost. Because this is amazing, up till this day, we cannot even imagine how these things were created. Because this is such a fascinating field and it is so difficult to understand. You can spend a lifespan and you may not understand embryology. So that's why I've made it extremely simple. It's very few slides and there is nothing to worry about, okay? So let's see. So what we are going to see, what is the overview? Very, very simple. Everybody can understand. Embryological development, urogenital system embryology. That's what we are focusing mainly. Little bit about rectal development. Few nice pictures about congenital anomalies in the urogenital system, congenital, rectal, anorectal anomalies, and clinical implications and summary. And it's very, very brief, so nothing to worry about. First of all, let's start with a very basic thing, which is how does it all start. And it is amazing that nature has given it a lot of importance because all the important things start in the very earlier phase of embryological life, very, very early age. Gradually there is finishing touches like all the cosmetic bits and all that, but the important things, they start in the very beginning. If you keep that in mind, you understand that obviously heart is the first thing, the heartbeat, it all starts from the heartbeat. But if you think about it, it starts in third to fourth weeks of early gestation, and 3 germ layers are the most important thing you need to remember. And these are the 3 germ layers which give rise to various structures. So if you have to have a starting point, all you need to remember is 3 germ layers. And we all know the name of the germ layers. Anyone can name it? Exactly, exactly. So, intermediate mesoderm is our key point. Okay, we are focusing on intermediate mesoderm, and it is key for urogenital structures. So, and then endoderm is the main one, which forms the gut and rectum. So, what do you think about ectoderm? What does ectoderm do? Any ideas? Something important? Anybody louder? So where does central nervous system come from? Something important as well. But because we are focusing on urogenital, so we are not going to detail. But what you can see, early blastula, early gastrula, and late gastrula phases, where we can see starting from blastocyst, and then we go to mesoderm, endoderm, and ectoderm. So this is how it looks like. It's like a jelly bean. It's very, very small, but it has started to take shape of a little human being. So we are focusing on urogenital system. So we are only focusing on pronephros, which makes rudimentary and non-functional part of the kidneys, which is in week 4. Now only God knows why this is there and why it is rudimentary. Because in adult life, normally we don't have any role for pronephros. Mesonephros is the one which is important. It gives us temporary kidney function, which is week 5. And then metanephros is the permanent kidney, which develops week 5 to 9. This is what we need to remember, metanephros. And then sequential development ensures functional renal anatomy. So it's a system which develops very, very basic system very early on, but it keeps polishing and gradually we get proper kidneys. So ureter and bladder development, again, it is a very simplified photo. Ureters, they arise from ureteric bud of the mesonephric duct. And then bladder develops from upper portion of urogenital sinus. So most important thing for all of you is to focus on urogenital sinus. And then urethra forms from lower portion of urogenital sinus and critical branching and integration for proper drainage. So this is just a very basic overview of ureter and bladder development. And then female reproductive system. So the word you need to remember is M. M for mother. You will always remember M for Mullerian, okay? So it is Mullerian, which is paramesonephric duct. They develop into uterus, fallopian tube, and upper vagina. So wolf is usually male character. So Wolffian duct, we don't have to do anything with that. So Mullerian, M for mother, and now you remember that. So Wolffian ducts are mesonephric ducts which regress in females. So proper duct fusion and resorption are essential for normal anatomy. So what's happening here? Things are being formed, and in ideal situation, there should be no interference of any external factors for them to be made normally. But sometimes there are problems, so things don't go according to plan. We will discuss why that could be a little bit later. So now we are talking about embryology of the rectum, as Professor Nasreen mentioned. Hindgut development, it is a mixture of endoderm and ectoderm, and in the middle there is a line which is cloacal or anal membrane. Normally, these two structures, they fuse and the membrane disappears. But if it doesn't disappear, then problems can happen. We'll discuss that in a minute. But for you to remember, it is an interplay between endoderm and ectoderm. And you notice there is no mesoderm in between, so it's endoderm and ectoderm. We'll talk about it. So hindgut origin is endodermal tissue completely, and cloaca is early common cavity for digestive and urogenital tract. And then urorectal septum, it divides the cloaca into rectum and urogenital sinus, and it's all by the end of week 7, but it's still very, very early. And it sets the stage for normal anorectal development. Let's go ahead. So now we talk about, that was the normal structure development. Now we talk about just very basic few congenital anomalies of the urogenital system. So they arise from disruptions in embryological processes. So what do you guess? What could be the interruptions? And baby is like a tiny, tiny jelly bean inside protected environment of the uterus. So what could be the factors which could disrupt this very fine development? Any ideas? Exactly. So there can be things in the environment which can harm little developing baby, which could be maybe some medication being taken, maybe some infection going on, yeah, maybe some antibiotics being given. Rarely, maybe some environmental factor, extreme stress, or some other things which can affect the normal development, because this is an extremely sensitive time period. But in addition to that, there could be problems with the chromosomes, yeah. So genetic problems as well, which can happen. There could be some gene mutations which can cause these problems. So there can be multiple factors which can cause these problems. So these congenital anomalies can affect kidneys, ureters, bladder, and reproductive structures. And impact on function may range from asymptomatic to severe to life-threatening. So many of us even don't know, maybe we have only one kidney if we never had any imaging or anything. So many of these things we will never know unless there is a problem and we get some imaging, and then we know, oh, we have only one ovary, still managed to get 4 children. Not bad. So sometimes it doesn't affect the normal function, but sometimes it can be serious. So now a few pictures. So we are talking about renal agenesis, that in the first place kidney doesn't develop, so that's renal agenesis. So absence of one or both kidneys, it may result in compensatory hypertrophy or renal failure, yeah, but not in every case. Sometimes one kidney is good enough. Hydronephrosis, swelling of kidneys due to urinary obstruction. What could be a common reason for obstruction causing swelling on the kidney? If we are talking about male fetus, yeah, exactly. Posterior urethral valves which block the urethra. Because if you think about it, fetus is all the time drinking all the amniotic fluid, going to kidney, filtering, going to the bladder, and then it's the urine which goes into the amniotic fluid again. But if baby is drinking water but not able to get out, the bladder becomes big and the back pressure goes to kidney, and kidneys got, they can get very swollen. Recently, we had a case of megacystis. Anybody has heard of megacystis? So I'll give you a scenario, so that will give you the importance of these things and important to know these things. So maybe it was only last month, that I was on call. I don't do much obstetrics, just once a month I do one on call. So I start my night duty at 8 o'clock and the consultant before me tells me that this patient has been in labor. She is only 28 weeks pregnant, has been in labor for a very long time, and she is known to have megacystis, which is a large bladder. The baby has died, so obviously we are trying to induce labor so this poor woman can deliver the baby. And patient is not delivering. She is multiparous, she should deliver, is only 28 weeks baby. Nothing is happening. She has had old induction. She is 6-7 centimeters. Baby is only, actual baby is small. So the consultant does the scan and he said, oh, it's 1 liter of urine in the bladder. That's why, very big tummy, so baby is not coming down, it's a breech baby. He puts a needle in the bladder and drains all the urine. He said, problem solved. So no problem, now she should deliver. And now 6 hours have passed after that and again she has not delivered. So now I start my duty and I have no clue because I don't do much obstetrics. So I examine the patient and what I feel, it's a breech baby, but what I feel inside the cervix is like a balloon, exactly like a balloon. In a short period of time, because of all this high placental blood flow, baby's kidneys actually, they had produced a lot more urine before the baby died. It was not 1 liter, it was 2-3 liters. So what I can still feel that it is still megacystis and there is no point trying more unless we drain it. So I just went through vaginal approach, made a little nick in the bladder, drained 2 liters of urine and within minutes patient delivered. So meaning to say such a simple thing, otherwise this patient would have been in labor for another maybe 24 hours or she would have ended having cesarean section. So megacystis is a condition which happens once in many thousands, but I happen to see it. So this is a good take home message that any congenital anomaly can come to you, you have to keep that in mind. Okay, then it makes it easier. So vesico-urethral reflux. So again, posterior urethral valves and then pressure goes back to kidneys and hydroureter hydronephrosis can develop. That was just a brief one. We'll go again to kidneys in a minute. So we are talking about Müllerian duct anomalies. Remember, Müllerian, mother, and it's all female genital tract, results from improper development, fusion, or resorption of the Müllerian or paramesonephric ducts during embryogenesis. It can cause menstrual irregularities, infertility, recurrent pregnancy loss, and obstetric complications. So you can see it is quite a serious stuff. Okay, so maybe you all might have encountered some of these anomalies, but this is something quite serious stuff going on. So what could be these anomalies? Uterine anomaly, we are talking about MRKH syndrome, where there is no uterus and there is no upper vagina. What a disaster for a female, yeah? So she has no uterus, she has no upper vagina, but she has normal ovaries. So what could be the presenting? And voiding is micturition reflex when the threshold volume is reached. Increase in volume and pressure elicits intense afferent firing, activation of dorsal spinothalamic pathway, and when timing is appropriate, the bulbospinal reflex coordinated by pontine micturition center is activated. So all of you, do you know what is the capacity of a normal female bladder? Any guesses? Yeah? Around 500 mil, yeah? So when a patient has overactive bladder, what is their capacity like? A lot less, isn't it? So what we tell patients that the size of a normal bladder is like a grapefruit. Yeah, it can hold around 500 mils. But when your bladder becomes overactive, it doesn't distend and the bladder muscle gets thicker. So size of your bladder has become like an egg. And that's how you can tell patient why they have to keep going to the toilet, because there is no storage facility. As soon as there is 100 ml is collected, they have to go because urine will not distend, bladder will not distend. So that's how you can tell them when we talk about non-surgical training by Dr. Seema, conservative management, that it is a problem of the size of the bladder. The size actually gets smaller, detrusor gets thicker, and how to make it bigger again, because this is a reversible problem. So that is the most hopeful thing, that it can be reversed. Okay, so overview of the continence mechanism. Bladder stretch receptors are activated, parasympathetic pelvic nerve stimulation, detrusor muscle initiates contraction, and if it is an appropriate place, there is voiding. Inappropriate place, urethral sphincter gets contraction and there is no voiding. But there could be problems with the voluntary control of micturition, there could be overriding mechanism, and various problems lead to various type of incontinence. If it is urge incontinence, usually the detrusor muscle becomes overactive. That's why it is urge incontinence. So patient goes to the toilet a lot, very frequently, and passes only small volume. And when they are getting to the toilet, before they sit down, when they are getting their clothes undone, they start to micturate. So that is called urgency incontinence. Second one is stress incontinence. There is nothing wrong with the storage phase. They can store urine okay. They pass big volume urine. They can hold it. But when they are coughing, sneezing, jumping, doing exercise, urethral sphincter gives way because it's a problem in the pelvic floor. Reflex damage, remember S2 to S4, when they have nerve injury, spinal cord injury, stroke or any other problems, or some neurogenic conditions, they can have reflux problem. Intrinsic sphincter deficiency like peripheral neuropathy can cause problems, and then paradoxic, which is overflow incontinence. Actually, there is retention of urine because of various neurological condition, and they keep leaking because bladder is not empty. So now this is one of the conservative management which you will be discussing, Dr. Seema, in one of your talks tomorrow, and it is the treatment using electrical stimulation. Now we are trying more and more to do things which are least invasive. Least invasive means without the use of knife, yeah? Trying to talk to patients or doing things which involve no blood loss or any surgery. So this is something which is really promising, and this we are doing more and more, electrical stimulation. So there can be various places where we can do stimulation, but the most easiest one is called PTNS, posterior tibial nerve stimulation. You heard of acupuncture? Yeah, small needles. So it is similar type of a needle on back of our inferior malleolus. On the posterior aspect, there is tibial nerve. So we put an acupuncture needle, and there is a battery exactly like this. It is attached to their patient, sits there for half an hour session every week for 6 weeks. So that is a stimulation of posterior tibial nerve, and then it improves symptoms by up to 60%. Okay. So that is something which is quite arduous. Patient comes to hospital, there is no infrastructure, there is no facility, and not possible to come every week. So there can be something permanent which is called sacral nerve stimulation. So tiny battery which can be put in the sacral region, which continuously stimulates sacral nerves, which is called SNS. The benefit of that is it is more than 80% successful. The best thing about SNS is there is no big surgery involved, and it is treatment not only for urinary incontinence, it is also treatment for fecal incontinence. If somebody has double incontinence, this is the best way go forward without using much any big surgery. The only problem is finance because it is quite expensive. The little electrode which you put in the sacral region, it is 8,000 pounds. So I don't know whether someone manufactures it in India. Oh no. Okay, but this is the commonest thing. This is the commonest thing in the UK if somebody has double incontinence. So just imagine a tiny cut there. No one knows what you have had, and it treats fecal as well as urinary incontinence. One of the best. Huh? 10 years. Doesn't take very long time. And you have like a little remote like thing with you. For example, if somebody needs MRI scan because it is magnet and all that, you can turn it off at any time. So it's really one of the wonderful things which changes patient's life. Okay. So we are talking about electrical stimulation here, TENS machine. Okay. So the last point here is about bulking agent. Bulking agents are a little inert material like a gel which we can inject surrounding the urethra, which is one of the commonest things which I do, but we will talk about it in day 3 lecture when we talk about surgical management of stress incontinence. Okay, now this is the stuff which can be helpful in India, okay, because this is medication, and we do a lot of medication in India, don't we? So that is one of the commonest things which are easy, cheaply available, but we need to know the side effects, and we need to be aware when not to give these medication, okay? So these are quite relevant to you to know that which receptors are there and which medications are related to which receptors. So So acetylcholine esterase muscarinic receptors, there is a physiology there, but all you need to know that anticholinergic medication are the most common medication which we use in the overactive bladder regime. Anticholinergic, you need to remember that, okay? And pathophysiology is all there, but all you need to know that anticholinergics are the most successful and the commonest medication which we use, but we need to know the contraindication which we'll discuss, and we need to tell patients about side effects because this is a lifelong burden of medication. Other types of receptors, muscarinic receptors, subtypes, and nicotinic receptors, but that is just academic interest, not much clinical. Clinical things I'm going to tell you. Alpha 1 receptors, beta 1 receptors, and the one which we are interested here are beta 3 receptors. Okay? So what you have to remember, only two things. One is anticholinergics and one is beta 3 agonist. So cholinergics are anticholinergics and beta 1s are agonist, which will augment the function of beta receptors, and in cholinergic it is opposite to the cholinergic receptors. So again, it is different types of receptors. Mechanism of action of anticholinergics, as it said, that is the most important group of medication. It blocks muscarinic receptors, particularly M3 receptor. Yeah? And it prevents acetylcholine esterase from binding and thus inhibiting detrusor muscle contraction. So the name of the medication is oxybutynin, tolterodine, solifenacin, darifenacin, fesoterodine, and trospium chloride. Out of all these medications, let's check your basic knowledge. There is only one in this group which doesn't cross blood-brain barrier. So all of these cross blood-brain barrier. We'll talk about why it is relevant. One is the medication in this which doesn't. Anyone knows which one?
Trospium.
Well done. You have perfect knowledge. So trospium chloride is the only medication in anticholinergic group which doesn't cross blood-brain barrier. What could be the relevance of that? The side effects. Yeah, because
Having cerebral stroke and all.
exactly. But the thing is, the common side effect of anticholinergic we are going to discuss are dry eyes, no problem, dry mouth, no problem, constipation, no problem. Not serious side effects. Yeah, but if somebody has myasthenia gravis and you give anticholinergic, they die. If somebody has glaucoma, you give anticholinergic, they get blind. So there can be serious problems. So you need to know these things. The problem is that when we read pharmacology, there is so many side effects that we forget about important things. So if you have to take home message today, the common side effects of anticholinergic, dry eyes, dry mouth, constipation, which is not a problem. We can counteract drinking sips of water, using artificial tears and taking laxatives every day, no problem. But we must know the contraindication, which is myasthenia gravis, muscular dystrophies, glaucoma, so which can have serious morbidity. Yeah, and long-term use of anticholinergic, because all of them apart from one cross blood-brain barrier. Anybody above age of 60, if they take anticholinergic for long time, which cross blood-brain barrier, it can lead to cognitive impairment, memory problem, balance problem. So you have given a woman a tablet to treat her nocturia, but when she wakes up anyway and goes to the toilet, she falls down and fractures her neck of femur. So a small tablet can kill her. Fractured neck of femur in elderly is a very serious problem. And in UK, because we have elderly population and most of the people are above 80, they live very long. So if I give someone solifenacin, her bladder is better, but anyway, it has given her a balance problem and her memory is declining. So you have done a serious, serious harm to patient, but not knowing that these medications cross blood-brain barrier. So anybody above age 60 or 65, my choice will be only trospium chloride, which is slow release medication, 60 milligram, comes with name Regulin in the UK. So just one tablet, slow release, 60 milligram, and she can have it long term without any effect on memory or cognition. Okay, so different types of receptors and different things, but I have told you all of that. So now we are talking about beta 3 receptor agonist, which is beta 3 agonist, you have to remember. And out of all that group, only one medication is there which is used in bladder. So it is called mirabegron. You must be available here, Becmiga. So most important thing you need to know about mirabegron, it doesn't cause constipation, doesn't cause dry mouth, doesn't cause dry eyes, but it causes rise in blood pressure. If somebody has uncontrolled hypertension, it is an absolute contraindication. If somebody has controlled hypertension and patient promises she takes her medication for hypertension, this can be given, but when we initiate the therapy, they must have blood pressure monitoring every week for the first month. Every week for the first month, yeah, because it can cause uncontrolled hypertension. So that's one thing about Myra background. Other two side effects are palpitation and headaches. If they promise, they will keep their medication, because in our countries how people choose, oh, today I'm not going to take any medication. So if they don't take blood pressure medication but they have taken Betmiga, it can give rise to uncontrolled hypertension, could have stroke. So we need to counsel them. So my preference is not to give them. And the second contraindication is the patient with renal compromise. So people can have Betmiga when they have renal compromise, but the dose is half, it is 25 milligram. We never give 50 milligram. The standard dose is 50 milligram, but we give only 25. Okay, we move on. So these are the medication which are used in erectile dysfunction, but they can be used in lower urinary tract problem. We don't use them in gynecology. And then the bottom one is about Botox, and that is one of the medication which changes people's lives. Yeah? So it is a toxin. It's a toxin which we inject in the blood. Do we have it here?
Yes, beauty.
Oh.
Every beautician has
Yeah.
started using
Yeah.
this.
It is very simple, and it is
And
something you can start.
you will have like very big Indian figures whose face has become plastic-like because of Botox
Yeah,
injection.
but it has best use in bladder.
Ask my pupils, they should be able to tell the names.
Yeah. Yeah. But in
पूरा
normal,
body, पूरा face उसका तो
yeah.
plastic हो
But
गया
this is
है.
something which is, it is something which can transform patients' lives. Because in overactive bladder, people go to the toilet 20 times a day, in the night 7, 8 times. It destroys their life. So many people get fired from their job in UK. If you are a nursery nurse and keep going to the toilet every half an hour, who will employ you? You can't be a teacher, you can't be a manager, you can't travel, because every services you have to stop. So this transforms people's life because no side effects, 70% success rate, and takes 5 minutes to do it. Flexible cystoscopy and Botox. So we can talk about it in detail, but this is one of the best things in overactive bladder. So these are the medication we were talking about, and I put it separately: dry mouth, dry eyes, constipation, beta 3 agonist, hypertension, palpitation, duloxetine. Anyone knows about duloxetine? Yeah. So what is the relevance here? Why did I put it here? What does duloxetine does to the bladder or pelvic floor? Duloxetine is the only medication which is the medical treatment for stress incontinence. Stress incontinence, the basic treatment is either conservative or surgical. The only medication which can help is duloxetine, because it has effect on the pelvic floor, external urethral sphincter. So it increases the tension in the sphincter, so it can improve the holding capacity. So this is a side effect of the medication which can be used for therapeutic use. But in my career as a urogynec consultant for 11 years, I have never prescribed it. The reason is serious side effects, and I would never prescribe it. But for students, you need to know there is a medication which can help. But as I said, I have never prescribed it because severe cramps, it causes severe nausea, severe cramps, severe diarrhea. So what is the use of being dry when you have diarrhea from other end? So no problem. So, yeah. So, but theoretical point of view, you need to know. This is the most important thing which can help in postmenopausal women. So, bladder, urothelium, and vagina and urethra, all of these have estrogen receptors. So, when somebody crosses age of menopause, which is usually after age 48, 49, the estrogen receptors are there, but there is no estrogen. So, all these areas, they become very, very atrophic, and sometimes all you need is just estrogens, and you do not need any. It is so surprising. It is such a common sense thing that local estrogen, vaginal preparations in the form of veggie roots or veggiefum pastries, estriol cream, just 10 microgram every night for 4 weeks, and then twice a week for 4 months. So that does the trick, improves urothelium, urethra, vaginal, and I'm sure you have it here. This is something you have. Desmopressin. Anyone heard of desmopressin? What is it? Something to do with antidiuretic hormone? analog, isn't it? So it is antidiuretic hormone analog. So it works as an antidiuretic hormone. So what happens, this is a treatment for nocturia. If a patient is going to the toilet once in a night, that's normal. More than once is called nocturia, okay? So it's a big burden because some people, they have cardiovascular problems, so in the daytime their bladder is perfectly fine, but the water keeps collecting in the lower part of their body because of varicose veins, because of poor kidney function. But as soon as they lie down, all that water goes back to the kidney, it becomes available to the kidney, kidneys filter and they produce a lot more urine in the night time. So their primary complaint is nocturia, daytime they are perfectly fine. So in order to cure that, we can give them desmopressin, which is antidiuretic hormone analog. But the problem with this is low sodium. It can cause low sodium, and if that happens, they can have seizures. So a minor problem, but can result in serious comorbidity. So anybody we start on desmopressin, they need to have kidney function test every week for first 4 weeks. And if they have low sodium, we immediately stop. And that is the main thing. Otherwise, it's an excellent medication. And always start, if the normal dose is 100 microgram, I always start just from 40 or 50 microgram, not with the full dose, just to see the effect. Yes, this is my favorite stuff, Botox toxin. So what do we do? It's a picture of the bladder with a cystoscope in the bladder. So the needle is like a hair, very, very thin needle. We do it under local in the clinic. So we put the scope in, we have a look that everything is normal, we put the needle in, and we reconstitute. Starting dose is 100 units of Botox with 20 mils of normal saline. We mix it up, but we never shake the bottle. It's a very big molecule. If we shake, it breaks, it doesn't work. So we give it 1 mil at 20 places. So patient cope very well. It's a very fine needle. Starts working in a week's time. We have to tell patient it doesn't work straight away. Takes a week for the toxin to work and paralyze the detrusor muscle. But it can change people's life. This is the favorite stuff. But 100 units is the smallest dose which we start with. If there is no benefit after 3 months, then we can book for 200 units. And if there is no benefit after 3 months, we can give 300 units. So maximum dose is 300. So it's a toxin. Why does it not kill patients? What do you think? The reason is the dose. So the dose which is required to kill a human being is 2,800 units. It's good to know, isn't it? So that we know that never ever to give any dose bigger than that, and we can never give. Maximum we can give is 300 units. A word of caution, it can cause urinary retention, and if that goes unnoticed, they can have recurrent urinary tract infection, big problem. So it needs to be a flowmetry or flow rate or bladder diary should be available if there is any problem. Post-micturition residual volume should be checked if they have recurrent UTI. Yeah? Sometimes we have to teach them self-catheterization if they develop retention. Whenever we give Botox, we give 5 days of antibiotics because risk of infection. So that's all about medication. Sorry, I'm taking long time, but any questions about medication? So if, actually it can last 8 to 9 months. If you give once, and sometimes it can last 1 year. And you don't have to have it lifelong. Patients only need 2 or 3 times, and then the habit cycle is broken. The capacity of the bladder becomes bigger, and they may not need it again. So it is something really good. Yeah, something to think about here if Botox is available for cosmetic reasons. Any questions at all? Anyone? About the quality of life? Yeah, quality is about quality of life. Yeah, all you need is a scope. Simplest thing.
Flexible cystoscope.
Yeah, yeah. Even the rigid cystoscope, you can put a bridge, and there is a needle which is not, because in England we have everything disposable. So we throw the scope in the bin. Next time I will not throw it, I'll bring it here. So somebody can manufacture it. Yeah, yeah. So I have 6 patients in one clinic. So I have six scopes which I use and put in the bin. Yeah. Yeah.
Thank you so much, ma'am, for such an insightful lecture. We really enjoyed. We'll now take a short break and we'll have tea. And we'll meet after 15 minutes.